Good afternoon. Welcome, everyone. Thank you for joining us for our Lunch and Learn webinar. This topic today will be a MICIS webinar focusing on opioid clinical update for 2019. We do have several speakers today. The main speaker is Elisabeth Fowlie, but Noah Nesson and Rajiv Advani will also join in the conversation throughout the presentation. I'm Kayla Cole. I am a consulting services manager here at Quality Counts, and I'll be facilitating the webinar for you today. Just a reminder for CME that today's speakers do not have any relevant financial relationships with the manufacturers of any commercial products and/or provider of commercial services discussed in this CME activity. CME will be available for participants who have signed into the live webinar. If there are more than one of you sharing a computer to watch this webinar, we ask that you utilize the chat box to enter your name and email address, and that way we'll have your email for the attendance records. We do not offer separate nursing CEUs, but you can still get a CME certificate. Once the webinar is ended by the host, you will get a pop-up on your screen that will immediately direct you to the survey. So this is a newer process for us, and it's important for people to note that if you leave the meeting before we actually end the meeting, you won't get that pop-up. So it's very important to just stay on. We will end the meeting, and then that pop-up with the survey will come up. If you have any issues with that, you can certainly email Jackie Tyner at jtyner@qualidime.org, and she can help you get to the survey to get your CME certificate. A few more notes about today's webinars. You are in listen-only mode, so we ask that you use the Q&A function to ask questions or make comments. You can put questions in throughout the presentation, and we'll have time at the end to address those questions. Your video screen size and location is adjustable, so if the box is in the way of the slides, you can drag it, move it around, just set it up what works best for you. And if you are joining by phone, again, or with others at the same computer, it is important for you to send your name and email to Jackie at jtyner it's actually qualidime.org. And today's funding for this webinar and for all of the MICIS webinars are funded through a contract from the Maine Department of Health and Human Services. So a little bit of background of Qualidime, formerly Maine Quality Counts. We're a nonprofit located in Manchester, Maine. As of January 1st, 2019, we did merge with Qualidime, another national healthcare consulting organization. And between the two companies, we now have over 50 years combined experience delivering healthcare quality improvement services. This also allowed us to expand our reach in New England, and we have offices in Connecticut, New Hampshire, Vermont, and Rhode Island, as well as Maine. As we merged with Qualidime, our vision was really to have one unified organization with over 50 years of combined experience delivering healthcare quality improvement services, and that we're committed to transforming the quality and safety and value of healthcare by leading, collaborating, and aligning improvement efforts. And the big goal, and it's kind of that lofty big goal, is to really look to work with you and to make New England the healthiest region in the United States. We still have the same priorities, though, even though we merged, because the company we merged with had the same priorities as well, was to improve the alignment of healthcare systems to transform health for all people, as well as provide quality improvement assistance to practices, engage consumers in healthcare, and promote the integration of physical and behavioral health. So a little trip down memory lane before I turn it over to Elisabeth. Many of you know about Caring for Me, and how it's been, I would say, since even a little bit before 2016, but I think it got formalized in early April 2016, where Quality Counts and the Maine Medical Association launched Caring for Me, a collaborative effort that really aims at bringing together partners and helping share tools and having communication between healthcare providers in an effort to support prevention efforts, maintain compassionate and trauma-informed approach to chronic pain management, improve the safety of opioid prescribing, improve access to effective treatments for patients with substance use disorder. Caring for Me is a program that we still have running. There's a leadership group that meets virtually every month. So certainly follow Qualidime and the MMA if you would like to join Caring for Me. You can also reach out if you have any questions on how to join Caring for Me, and we can help you become part of the solution. So for today's webinar, we have 3 objectives. Really, it's focusing on reviewing the latest research relating to opioid and pain prescribing practices, constantly consider harm reduction, and discuss opioid use disorder and treatments. So our main speaker today is Elisabeth Fowlie. Elisabeth is a family physician living in Holden, Maine, and practicing part-time as an adult hospitalist nocturnist at Eastern Maine Medical Center in Bangor. She does consulting work and teaches for the Maine Medical Association's Academic Detailing Program, MICIS. She attended Colby College and Emory University and received her MD from Vanderbilt University School of Medicine. After a residency in rural family medicine, she received her MPH in health policy and administration from UNC Chapel Hill. She is a past president of the Maine Academy of Family Physicians and a prior alternate delegate to the American Academy of Family Physicians. We also have Ranjiv that will be joining us. I'm going to give him a little bit shorter of a bio because him and Noah have some long ones too. But Dr. Radvani has been, instrumentally involved in a lot of work that goes on in Maine, especially implementing buprenorphine inductions within EDs and helps support EDs through that work, and serves in his role as Blue Water emergency physicians. And then we also have Noah Nesson joining us today. And I don't think there could ever be enough said about Noah Nesson. He's a wonderful family doctor that's always been supportive of these efforts and really takes a leadership role in helping the state of Maine move forward to meet patients' needs. So with that, I'm going to turn it over to Elisabeth, and she will go through the presentation from MICIS.
Hello, everyone. Welcome to, I think it's Tuesday noon time on a nice day. Usually when we have these webinars, it ends up being stormy. Mm-hmm. So again, MICIS is a program of the Maine Medical Association, which receives its funding through the Maine State DHHS. And we're talking a little bit today about opioid clinical update. So the reason why I started this topic was because we are now 3 years into this new law, Chapter 488, which was passed in 2016. And that new law included in it 3 hours of mandatory education for all prescribers and all MDs, even if they don't prescribe, and PAs who work with MDs who don't prescribe, that they have 3 hours of CME focused specifically on opioids every cycle. So when you renew your license, you need to attest to the fact, and sometimes you'll have to send in certificates to the fact that you've had 3 hours of CME. So that started in 2016. So at this point, most providers in Maine have had a lot of education on opioids and really seem to know the basics. What is an MME? What are the harms associated with opioids? So my goal this year in this class was to try to just say, what's new? If you're not on this wagon of constantly being on Caring for Me calls and going to all of these conferences, including the fabulous conference, statewide conference back in July about opioids and the opioid crisis, then what are some things that you might want to be up to date on, given that you have a pretty good foundational knowledge of opioids? So that's sort of the genesis of this, and wanting to be completely trendy, even though I am now in my 5th decade, I named it #OP19 for Opioid Update 19. So that's to get the young people interested, right? I have never actually checked on social media because I don't actually know much about it, if anyone has picked up my hashtag, but we'll see. So again, disclosures, we've already gone through this. I will point out that we will be sending out 2 handouts along with the notes from the lecture, and there may be evidence-based but off-label uses of medications on the handouts, so I have to disclose that as part of the CME. And we've already gone over objectives. And so we're going to talk a little bit about the changing focus on opioid prescribing. And I wanted to start with a patient story to kind of ground us in terms of where are we going and what are we doing with this work. So I wanted to tell you about a patient named Emma. And luckily for me, I always forget patients' names, so it's not difficult for me to completely change things and be HIPAA compliant. Emma represents a very common patient in our hospitals in the state of Maine, so her story can be generalized to a lot of patients we're seeing. Emma uses drugs by injection, mainly heroin, and she had an epidural abscess and came to a hospital. She got surgical release or surgical drainage of her abscess, and she was on intravenous antibiotics in the hospital. So post-operative day, maybe 2 or 3, I was covering the house. So in the evenings, we have one person who covers all of our inpatient medicine service and consult service, and it's over 200 patients. So I got this phone call from the nurse. Emma is out of control. She's screaming. She's asking for her opioids early. She's really a difficult behavioral issue. She said a lot of derogatory things to the nurse, and the nurse calls, and the nurse is very, very emotional about the fact that she feels like that Emma is not treating her well. So in that first conversation, I said, okay, let's take just a second to step back from this and let's think about Emma. Okay, Emma was using a lot of opioids before she came in the hospital, and now in her post-op period, she has pain, and we are probably not helping her to get her basal opioid dose, what she was on at home. And I said, you know, when Emma's screaming at you, that's her addiction talking. You have to take a step back and say the patient's disease is probably what's responsible for them to be acting this way towards me, and try to think about it and try not to take it personally, try to take a step back. So I think I increased her medications a little bit. We talked a little bit about even us in medicine, we still have this idea that when someone comes in the hospital, if they want more and more medicine, that they're drug seeking. And the idea that these people are on a basal dose of medicine at home has not really entered into our thinking when we're trying to transition people from outpatient intravenous high dose opioid use to inpatient. So I tried to work on things calm down, settle down. The next night I got called back. There was another issue with Emma. So I said, okay, so I went up and talked to Emma. There were a couple of things when I talked to Emma. I said, number one, you know, I think we really need to work on getting you on buprenorphine, known as Suboxone. Do you have any experience with that? And Emma said, oh yeah, Suboxone. I was on that 2 years ago when I was pregnant. It's the only time I've ever felt normal. So that was a great way for me to say, she's been on it before, she knows the benefits of it, and let's see if we can transition her to it. So we talked about what it would take to transition her from her post-operative pain management into being on buprenorphine in the hospital, because she'd be there for several weeks being treated for her infectious process. So we talked about that. Emma pointed out that she didn't have insurance coverage anymore. This was about a year ago, and so I want to talk about some of the things that have changed. So we went all through that, and she talked about herself and her interactions with the nurses, and there were some hard feelings on both sides of the fence. And when Emma talked about herself, she used the term addict when describing herself and how she was being treated by the nurses. And so I said, Emma, you know, we're trying to change the way we talk about things. You're a person with a substance use disorder or an opioid use disorder. And she kind of, you know, said, oh, that's ridiculous. So I went back and saw her like the next night and said, hey, we really need to get you transitioned over to buprenorphine. Are you willing to go ahead and do that? And she said to me, hey, I was talking to my mom, and I told her that I'm not going to call myself that anymore, and I'm going to have this new name for my disease. And what'd you say it was? And she got out a notebook and she wrote down person with opioid use disorder. And she wrote it down so she could practice saying it so she could call herself that instead. And so that was all great. And so those were some of the wins of this situation. I said, Emma, I'm not going to be back for 2 more nights, but you know, when I come back in 2 nights, I need to talk to, we need to get you off these acute pain medications and get you transitioned over to buprenorphine. She was very reluctant to go through the 12-hour period that it would require for her to be off all opioids to get started on the buprenorphine. 2 nights later, I went back and she had left against medical advice. So that was definitely not a win, right, for me, trying to be one person working part-time at night to try to get someone in a system that really wasn't equipped to help her. So I wanted to talk about some of the things that are different now, a year later, that maybe if Emma comes in the hospital now, there are things that happened. Number one, Medicaid expansion. Emma could probably qualify to be on main care and get her medication paid for. Number two, in Bangor, we now have a bridge clinic or rapid access clinic, which Noah's going to address a little bit later. And I don't have to worry if I start someone on buprenorphine in the hospital that I can't find a place for her to go to when she gets discharged. That it was such a difficult thing, and our care managers didn't feel well equipped to do that kind of discharge planning. And now we have a place where people can go to where they can get continuing care. Number 3, our emergency department is becoming more familiar with going to talk about. And so I'm hoping that that's going to spread to our inpatient service. We don't have a fairy godmother that's going to come and fund and provide the person power to do a full-time addiction medicine consult service at our hospital, as well as multiple other hospitals in Maine. So we're going to have to learn how to do some of this ourselves. And that's starting. Physician training, we're starting to think about addiction differently. And when patients come into the hospital who are using opioids high dose on the outpatient area, to think about how are we transitioning them into inpatient care. There's been a change in I think, nursing awareness and nursing thinking in terms of learning more about addiction. And then we're also thinking more about stigma and language. And so people like Emma can write down in their notebook and begin to talk about themselves as they enter recovery as a person with a substance use disorder. So that's the patient story to start with. I'm going to go quickly through some of the things that I think that people already are well aware of. And that is that we over the past 20 years in the United States had been prescribing more and more opioids. The peak was about 2012 to 2013, but then you can see already in New England by 2012 to 2017, prescribing was decreasing. The darker the color, the higher the rate of opioid prescribing. And we can see all over the country, this is in 2015, so starting to come down off that peak, the areas in the country which had the highest rates of prescribing. And so I'll point out Northern California, Los Angeles. We've heard a lot about the Ohio River Valley in terms of Southern Ohio, Western Virginia, Eastern Kentucky, Northeast Tennessee. We've heard a lot about that area, and we know that there have been difficulties in New England, Maine, New Hampshire, in particular Vermont as well. So things are improving, but we're still prescribing 3 times what we were at our baseline. So we've done a lot of work and we've made a lot of progress. We're going to talk a little bit about, has the pendulum swung too far? But at this point, we are still giving patients, or at least within the past couple of years, 3 times what we were 20 years ago. So there's been some progress made, but our prescribing habits still remain changed versus 20 years ago. So you can see that I haven't gotten in touch with my graphic designer yet to help me with this slide, and this was done by me, the family doctor. Hopefully I'm in her queue to get a more beautiful slide. So these numbers from the PMP were released last week, and looking at the total number of dispensations of prescriptions that were over 100 MMEs in the state of Maine, starting in 2014 to 2019. So I'd like to point out that even before 2016, from 2015 to 16, there was a 16% decrease. So that was before the CDC guidelines, that was before the Maine state law. We were doing some education on that to providers and prescribers, but there wasn't any huge national movement, and there certainly wasn't any legal movement toward that, and we had already started that decline. So then you can see in 2016, with the prescription guidelines and the Maine state law, there was a 38% decrease. So that accelerated, really doubled the rate of decrease. And then in the years since then, things have continued to decrease. You can see 17% drop in the 2 years since then. And the numbers for 2019, I will point out, I extrapolated them, the data, they only had data partially through the year. So I did a proportional figure based on what they had through the first 6 or 7 months of the year. And so that would be an estimated amount by the end of the year. But if things are decreasing, then that actual number might be lower by the end of the year. But I wanted to compare apples to apples. And then the average MMEs on these high-dose prescriptions have come down in that same timeline. I left 2017 blank because I shot back an email to the lady from the PMP that their data made no sense for that year, and she's looking into it. They had 255 for 2017, and I said, that's clearly not right. So, but we can see that there's a decrease in the average MMEs per day for these patients on chronic opioids. So that brings us to the current recommendations to try to do things multimodal, multidisciplinary. with a biopsychosocial view and thinking about things we really want to be thinking before we write that first prescription for people. So we have a chance to sort of affect the next generation in terms of how people are treated for pain. And then we have this really difficult situation, which we'll talk about in the middle, of these patients who are caught in the middle of this in the past 20 years who received high doses for long periods of time. And then really most of the guidelines are saying a 3-day supply for acute pain. I want to point out a study I ran across last year, which was a great study of postoperative pain control for total knee replacement, which is a fairly painful procedure, but there's been a lot of evolution in terms of how they think about using multidisciplinary pain, including regional anesthesia, including those really fancy schmancy ice machines that have the coolant thing that you keep on. So they have made a lot of evolutions in pain control for total knee replacement. But this study looked at people who were given opioid pain medication for the first 24 to 48 hours, and then no more opioid pain medication. They were randomized. And then patients who received opioid pain medication for up to 7 days. And at the end of 1 month, there was no functional difference. So this old argument of you need to take your pain pills so you can go to physical therapy and get better, that kind of takes that out of the equation, because the patients who got opioids for pain management and the patients who didn't get so much opioids for pain management had the same functional outcome in terms of their recovery, which is nice because you can really measure range of motion and things like that at 1 month. So this is a handout we're going to include tomorrow. It's not intended to be a comprehensive. Someone asked me where acupuncture was on this the other day. It's not intended to be comprehensive. We have good data about acupuncture, but this is just sort of a general thought process to start thinking about different types of pain and thinking about where we might use different medications. So this is a really big picture overview, but we will send this out along with it. I'm not going to take the time to go through all of it, except to point out in chronic pain, #1 recommendation in any type of chronic pain is CBT or psychotherapy in terms of helping patients work with their pain. So we're going to talk a little bit about the CDC guidelines. We know from the CDC guidelines and from our other review of the evidence that there was a lack of evidence that high doses and long-term use of opioids gave any benefit to patients, and we saw more and more that there was trouble. So the question is now kind of begs this question of, well, what about these people who've been on high doses for long times? So an article came out in the New England Journal of Medicine of it was like a commentary, not an article, April 2019, that talked about some of the original authors of the guidelines 3 years later. What they had noticed is maybe some unintended consequences or some people misapplying some of their recommendations. So one of the things was to consider the population. They said that they had heard reports of patients with terminal end-stage cancer being denied opioids for pain management, and that was never anyone's intention. We know that these guidelines apply to chronic non-malignant pain. That being said, we have to be careful with patients with history of oncologic disease. I had a patient who was on high doses of opioids who for 4 years in his oncology record, it was documented that he had no evidence of active disease. And so that gets a little bit tricky. But when we're talking about patients with clearly advancing end-stage terminal metastatic cancer, they should not be denied their medications, and that has happened. They talk about no hard limits, that the state laws are guidelines, and that's really why we have a palliative care exemption, that if a patient doesn't fall in any of those other categories, they might be able to qualify for a palliative care exemption. They really argued against abrupt tapering or discontinued, not cutting people off, not just firing people willy-nilly because they are using opioids, but working with them. There was some data in the VA that indicated that veterans whose opioids were abruptly tapered or abruptly discontinued did have an increased risk of suicide. So we need to take into account some of the difficulties in applying these recommendations. Now, we know clearly that we don't treat suicidal ideation with opioids, but when patients aren't tapered in a compassionate, comprehensive manner, it can cause some things like underlying depression and some other maladaptive coping strategies to become more clear. And those are the difficult situations where people need help. And then we've already taken care of it in Maine that MME thresholds should not apply to MAT. Those of you who did MAT back in 2016 and 17, like I did then, will remember that we got a report on every patient every quarter that we were over the 100 limit, and they were using conversion factors for buprenorphine, and that went away in 2017. So when you write a script for buprenorphine, you're not getting a over threshold report every time for every patient on buprenorphine. So that we've already taken care of with our PMP. So in terms of patients on high doses, we want to work with them comprehensively. We want to take a really empathetic, compassionate approach. And then they're talking more about patients who are willing to try a taper to work with them to taper down. Now that's going to be a little bit difficult, the patients who are very resistant to tapering, and that's going to be one of those situations where there might not be a right answer and we're going to need a little bit more help. Taper slowly. The original CDC guidelines talked about 10% per week, and we know that for a lot of patients on chronic high doses, that's too much of a taper, so maybe 10% per month might be a little bit better for patients on high doses, but also you want to have a plan and an endpoint in mind. So 12, 18 months down the road, you want to be at that point where you can think about having that patient off the medication. A 5-year taper might not make a lot of sense, but there are no hard and fast rules and not a lot of good data to tell us exactly how to do this, and every patient is different. Patients who continue on high doses, we need to increase our monitoring. On patients over 100, the guidelines are to see the patient face-to-face every 30 days. If they're over 100, because the risk of them dying from that prescription is so high that you need to see them in the office every month, because what you're giving them is highly likely to kill them. And patients on any chronic opioid should be seen face-to-face every 90 days. Those are the guidelines, the recommendations. And then work on trying to make it safer for patients who are on high doses. There's a CME course that's free through Stanford online that goes through this BRAVO protocol, which was developed by this physician Lemke, who is also Anna Lemke, who's also the author of Drug Dealer MD, which was a fairly interesting read along the lines of Dope Sick and the Sam Quinones book. Dreamland, thank you. And so it's just a mnemonic to remember how to go about compassionately and empathetically thinking about tapering patients. Now, I will warn you, if you want to sign up for the CME, you have to register for 2 different systems, and it takes about 15 minutes just to register for the CME. So I'm registered for it, but I haven't taken it yet. But it just talks about this approach. And then in this article by Chu and another author and Lemke, they talked about thinking about prescription opioid dependence, which is not currently a diagnosis. But for those people who are in that gray zone, who aren't clearly opioid use disorder, but have been on high doses for a long time and are sort of borderline, to think about those patients maybe in that gray area, and to think about buprenorphine, which would be an off-label use for someone with this unofficial, not formally recognized through the DSM-5 of prescription opioid dependence, but they wanted to bring that up as an idea. This guide the link will be in your materials. It's from the CDC. It actually does pretty well because it talks about decreasing 10%, but then it talks about some patients might need a slower taper. So this is pretty quick. I kept the little link on the phone so you could see it. I just wanted people to know that that's out there. And then I'll do a quick time check. I have about 10 more minutes before we bring our guests on. So perioperatively, there's a 6% chance that opioid naive patients will become chronic opioid users after 1 postoperative dose of opioids. That's pretty mind-boggling. And we know that patients who have multiple doses of opioids after an acute surgical procedure are at very high risk of still being on opioids 1 year later. Now, obviously, this is all changing. This goes through a little bit in terms of higher risk. So patients who have these comorbid conditions are the ones that maybe need the most what I'll call anticipatory guidance prior to acute and surgical procedures. We know that there's an association with post-op delirium and opioids, but there's also association with pain and delirium. So trying to manage people comprehensively and being careful, these are old recommendations, but still pertinent to us today. There's some data, this is an article from 2018 about the perioperative administration of gabapentin, and that's something to think about. I know that a lot of people in anesthesia are thinking about incorporating this, and to think about a very short-term use of gabapentin in that fact. And then also just awareness. So this study found that when people were given recommendations about what to do in current practices, that alone decreased the opioid prescribing for surgical services. So if we were at a live class in a room, now we would break up and we would pull out the formerly known as Quality Counts Guide to Substance Use Conversations, which here's the link. And we would talk about using language and being careful about language to say all of these 5 things in the middle in color. Those are the words we want to be using instead of the terms that we're trying to get rid of. So trying to sort of change our language and change the way we talk about it. And I think it's kind of cute. I've seen Governor Mills speak now twice in the past 3 months. And she's so good, like she tripped up once and she corrected herself right away. She started to say one of the words that we're trying to not say, and she got herself back on track right away. So I think it's nice that there are a lot of people who are paying attention to how we speak about things and the language that we use. So a couple more studies of interest in the last couple minutes. The SPACE trial from the VA. Now, very sort of like full disclosure here, this was non-blinded. It was not a placebo-controlled, double-blinded, blah, blah, blah study. It was randomized, but it was non-blinded. They took the patients with largely with osteoarthritis, chronic pain, put them into 2 arms. One arm had a 3-tier dosing of medications for their chronic pain, and that did not include opioids, and the other arm had 3 tiers of opioid treatment. They watched them for a full year, which there were no studies with opioids that went out for a full year to look at chronic pain. The really interesting findings from the study were that at the end of 12 months, there was no significant difference in pain-related function. So the patients who didn't get opioids were able to function just as well as the patients who did get opioids. And then more importantly, the patients who didn't get opioids had less pain at the end of 1 year than the patients who were treated with opioids. So this study is a start. It's not huge numbers, but it's a start. It's sort of the first study that we have that follows people for a full year. Here's an older study from 2010 that just talks about the increased risk of out-of-hospital cardiac death in patients, older patients who are prescribed opioids for arthritis. And so we do need to be careful when we think about non-steroidals. There are lots of risks to them, but we need to constantly think in mind that there are a lot of risks to opioids too, and that it's not always the safer choice. And then Athenahealth, I think the take home from this study was that people in the most rural counties, so in the designation of ruralness, very rural, which is a lot of Maine, those patients had an 87% higher chance of receiving an opioid prescription. So yet again, your zip code determines the type of healthcare that you receive, and we need to be cognizant of that when we're in a rural state, that some of our patients have been historically at risk for receiving higher doses just because they're in a rural area. And that, of course, is changing, just like everywhere is decreasing. But that some of our patients in the most rural area at the most high risk. Maybe that's because there are a lot of limitations for patients in rural areas. There aren't specialists, there aren't referral centers. It's not easy to get them to physical therapy. And heaven knows there aren't a lot of those ancillary services that you might find in a more metropolitan and certainly in a more wealthy area. And then finally, the dentists are on board. They had a big article last year in terms of they looked at a systematic review and found that ibuprofen combined with acetaminophen had the highest association with treatment benefit and the highest proportion of patients reporting maximal pain relief. So 3rd molar extraction, you don't need your opioids anymore, right? I had 2 teenagers who had 3rd molar extractions in 2018. Both of them ended up with multiple dry sockets. And both of them, including the one that's not quite as hardy as the other one, both of them did fine on their ibuprofen and naproxen, and they made it through. And so thinking about this rite of passage in older teenageship now as not being people's first exposure to opioids. And we're going to talk a little bit, I think we have about a couple more minutes before our guests chime in so we can get to talk about harm reduction. There's a big harm reduction conference coming up that AdCare is coordinating and registering for on October 4th. I think it's at USM, but don't quote me on that, but big statewide harm reduction conference coming up. So we all know, we've all heard the news that the Maine overdose deaths have come down, and hopefully that was the peak and it's going to come down and continue to come down. We know that this is due to a lot of factors. There is less opioid prescribing, there is more naloxone available, and there is slowly more treatment available for people with opioid use disorder. But we still see that we have a long way to go. As Governor Mills pointed out the other day, I believe it was her, she said, we still don't need to celebrate that we had 900 drug-exposed infants born in the state of Maine last year. It's better than 1,000, but having 900, which is something like 1 in 9 of our babies, is still not a cause for celebration yet. These are by the different counties if you want to know where your county stacks up. Most people kind of have a sense of where things are. I know from Penobscot County that we had some of the highest rates of dispensation, and we have some of the higher rates of overdoses for sure. Washington County, in some factors, including this one, shows up as having a higher incidence of overdose. We also know when you look at population adjusted rates that we see higher rates of overdose in our service center big cities. So in Penobscot County, Kennebec County, York and Cumberland County, we see that as well. So thinking about harm reduction, we are all thinking about now being very conservative in terms of prescribing opioids or not prescribing opioids at all, limiting supplies to 1 to 3 days for acute pain. And that's like acute severe post-operative surgical pain, right? For acute mild to moderate pain, not even using opioids. To really think about benzodiazepines, and I'll put in a plug for our webinar in November where we're going to talk about co-prescribing with benzodiazepines. And that will be a repeat with improvements from a 2018 webinar. We want to think about using comprehensive strategies. We want to be working really hard to talk about informed consent because for those patients, and there may be a subset of the population who ends up over 100 MMEs chronically, those patients are at very high risk of dying. And we need to be talking a lot with those patients and their families about the risks of continuing on those medications. And so when we say avoid co-prescribing with benzodiazepines, we do want everyone to co-prescribe with naloxone. And a lot of the insurance companies and pharmacies are now triggering alerts to say, if you're writing a prescription for such and such for your patient, why aren't you also writing a prescription for naloxone? So I wanted to go through, we've all heard these data, but I always think it's interesting to see them in terms of visually. These are heat maps of overdose in the United States starting in 1999, sort of into the opioid epidemic. And so you can see things that were happening nationally. The darker blues are low overdose rates, and the more red it gets are the higher overdose rates. So even at the beginning, we can see the little beginning of things there in Southern Ohio. And I'll just flip through them from year to year. I think that's the last year. So 10 years from now, we'll be able to see them go more blue. Also, as an epidemiologist thinker, I'd like to know what it is about the north central United States that has kept them lagging behind the rest of us through these 20 years of the epidemic. Quick stuff about drugs involved with overdose. Most overdoses involve multiple substances, oxycodone, heroin, fentanyl now. Cocaine is making a resurgence and methamphetamine as well. And we know that 70% of overdose deaths, this is nationally, with heroin or fentanyl had each other involved in them as well as cocaine and then alprazolam, and they didn't even look at alcohol in this study. Another pointer that alcohol still kills more people, it just does things slowly, sort of the forgotten substance use disorder. And then still nationally, maybe 2/3 of all deaths are related to opioids in terms of overdose deaths, and about 40% still involve prescription opioids. So we've made some progress, but we can't say that the problem is completely eliminated. So we're going to talk about Save Lives first. Looks like I have 2 minutes left. I want to talk to you about, I'm naming this the Quirion Challenge. So many of you know Eva Quirion, who's a DNP who works at St. Joseph's Hospital in Bangor, and she does a lot of work on addiction, chronic pain. She's probably tapered more patients off of opioids in the state of Maine than anyone else I'm aware of. And so she has an incredible firsthand knowledge of working with these patients. So on Saturday, she posted on Facebook that she went to her PCP and she got a dose of naloxone to carry with her because she had driven by what appeared to be an overdose. And there were already care providers on the scene, so she didn't feel like she needed to stop, but she thought, what if the next time I drive by and the care providers aren't there? And so we want to point out that naloxone is legal for third-party prescription use. It is the only drug that you can legally prescribe to someone knowing full well that it's to be used on someone else. There's good Samaritan immunity, even if you're a healthcare worker who stops and uses this on someone. And then you just have to think about payment and cost. You can get it through insurance, but you may choose to pay out of pocket. There are these big reports about this nurse in Boston who was denied life insurance. As far as I know, that's been remedied, denied life insurance because she got a prescription for naloxone. And then I put the number on here, PCHC, Dr. Noah Nesson has offered to write a prescription for anyone in the state of Maine. So I'm going to take the Quirion Challenge. I'm going to call this number at PCHC and ask for a prescription from Dr. Noah Nesson. And I'll tell you what product I'm going to choose. I think I'm going to go ahead and pay out of pocket. And so I'm going to use the naloxone pre-filled syringe because I know how to take it apart and put it together and use it. It's a lot cheaper than the branded Narcan nasal spray. So $30 to $40 for 2 doses versus $150 for 2 doses. So I feel pretty comfortable that I'm going to go with my naloxone pre-filled syringe. I'll put it in my trusty backpack and I'll have it with me and I'll be participating in the challenge. Also for organizations, you'll know that the state of Maine purchased a large number of naloxone and they're available through the new Director of Opioid Response Office. If you Google this, naloxone survey form maine.gov, you will get this survey form. It's very low tech because it probably would have taken them 5 years to figure out how to make it fancy and online, but you fax or send them in this survey form and they will put you on the list to be considered for distribution of the free naloxone. And Health Equity Alliance and there are some other groups who are also distributing this. So I think we're at the time now. We're going to talk about MAT and MAT in our community. And I want to just go ahead here to say there have been some expansions of buprenorphine and there are some evolving programs in Maine. So we're going to talk a little bit about, I asked Dr. Nesson and Dr. Advani to talk a little bit about their programs in terms of things that are evolving and changing in Maine. So I think, Dr. Nesson, can you unmute yourself?
I can. Can you hear me okay?
Yes.
I can hear you.
Great.
Everyone can hear you.
Here's my own naloxone. Can you see me as well?
Yeah, we can see you on video.
All right.
We can see you.
Sorry.
I'm trying to mute myself and it's not happening.
All right. So here's my own naloxone and we've been fortunate to have a grant to help us purchase naloxone to give away to our patients. We're going to offer it to all of our employees soon. If you Elisabeth, I would offer you a free one if you want it, and anybody on this call. We've got plenty. We have to be organized in how we track what we're distributing, but if anybody wants to email me to get a free dose of naloxone, I'm pretty confident we can get it for you. But Elisabeth asked me to talk quickly about our Bridge Clinic, which we opened on May 13th. The Bridge Clinic is intended as a very low barrier medication first model for Suboxone for people with opioid use disorder, and really targeting people with severe opioid use disorder, trying to get at the population of people who have the highest risk of dying in the short term from their use disorder. So our model is that our 4 walk-in care providers at our site on Union Street, within 2 weeks of discussing this with them, got their waivers. They're supported by the Director of Walking Care, Dr. Andrew Fletcher, who has his waiver. And we have 2 Bridge Clinic ongoing prescribers, Warren Shearer and Amy West, at our Union Street site. So the 7 days a week, people can access same day walk-in availability of getting Suboxone initiated. Very low barrier. We do a urine drug screen to make sure they don't have methadone in their system. We do, obviously, an evaluation to make sure they have opioid use disorder, get them started on medication, get them a follow-up appointment in the very short term with one of those 2 ongoing prescribers, and then they get 1 to 2 week prescriptions thereafter, as long as they keep coming back and make their appointments. We've served over 100 people since May 13th through that Bridge Clinic. We've had, because the volume overwhelmed our capacity, we've had to tighten up our eligibility criteria so that we're trying to reserve it for the people who are most unstable. So if somebody is what we call street stable with Suboxone, we don't take them into the Bridge Clinic program right now. If they're obviously in another program, we don't take them into the Bridge Clinic program right now. But this program is serving people who are really have been either present on their own, which is the majority, or have been referred from an emergency room after an emergency room visit for a use disorder related illness, or not, if they've been diagnosed with a use disorder and don't have access to treatment. We are working to add capacity, prescribing capacity in that clinic, and when we do that, we hope to loosen up those criteria again, because everybody feels badly about excluding people from the Bridge Clinic. But it's overall been clinically an overwhelmingly successful model. Operationally, it's been a challenge. You can imagine this is a new paradigm, and getting everybody on board with this paradigm is challenging. Communication is challenging. It was much higher volume than I predicted. I've lost several bets on the volume that cost me jars of pickles. But when you think about treating 100 people who previously had not had access to treatment, that's really important and gratifying. And the people who do the work, although it's challenging, speak very highly of their experience in doing the work. So somebody just asked what my email is. It's nnesin, N-N-E-S-I-N @pchc.com, just to quickly answer that question. And I'll stop there.
Thank you. Both Dr. Nesson and Dr. Advani are jumping in the middle of 18 other obligations. So they may be here through 1 o'clock, but they may not. And I'll do my best to answer their questions when we go to that. Dr. Advani, he looks like he's unmuted.
Can you hear me?
We can.
I tried to start my video, but let's see. Doesn't seem to be working. But if you can hear me okay, I'll just sort of talk about our program.
Yep, that's fine.
And what we've done, let's see. Yeah, the video is not working, I'm sorry. So I am the medical director of the emergency department at Midcoast Hospital. I'm the president of the medical staff there, and a partner in Clearwater Emergency Partners. And, what I'm going to talk about is our program where we began ED-initiated buprenorphine for people with opioid use disorder while they're in the emergency department. And I'll tell a quick story of how we kind of got there, and then tell you a little bit about the RISE program, which we're working with right now. So you guys were talking a lot about, all the different fronts in which we can sort of fight this epidemic. And in the emergency department, there's essentially 4 pillars of that. One is looking at prescription habits and tracking prescriptions for your providers. From a harm reduction standpoint, dispensing Narcan, and most EDs are now starting to do that. Looking at alternatives to opioids for pain relief while either in the emergency department or on discharge. And then the last pillar is ED-initiated buprenorphine. This really came about after a study that came out in 2015 from Yale, in which they looked at 3 groups of people who came to the ER with OUD, either looking for help or identified by screening. And they either did the traditional kind of handshake and a phone call, a brief intervention, or the last group got buprenorphine while still in the ED. And they showed that twice as many people were still in therapy at 30 days, so 80% versus roughly 40%. So we read that paper interested in when it came out in 2015-16, and we pondered it, and finally we got a work group together at our hospital in late, I'd say 2016, with the ED, our partners at the Addiction Resource Center, which is a mid-coast program, and then also with Maine Behavioral Healthcare, who provides crisis services in the ED. And we met together for several months and kind of banged out how we would do this, and went live in the fall of 2017. And really at that point started then talking about it to other EDs. And even before we went live, we started talking about it to other EDs. And I have to say, in the couple years that we've been talking about this, we've really seen a sea change in people's reception to us. I think when I initially started talking about this to a group of directors in the Maine Health locations, it was met sort of lukewarm, and I think a lot of people thought this was kind of a crazy idea. But really, even nationally, this is getting a lot more attention as something that your ED should be doing. And so now, and as we started rolling this out, we got inquiries from other EDs of really how to do this and help them set up the nuts and bolts of it. So we did some outreach to Miles and to Penn Bay and some other places, Central Maine, other places. And then several months ago, we partnered with Maine Quality Counts, then and now Qualidime, and Leah Bauer from our Addiction Resource Center, and Elaine O'Connor from Maine General to start Project Rise. And now we actually have some infrastructure, mostly thanks to Kayla, to actually go out and go to emergency departments around the state and provide education. And that education can really be, and anywhere we can meet you where you're at. You know, if you're really totally brand new at this, we can take you through the rationale for doing it, the nuts and bolts of the protocols, how to actually win hearts and minds, that kind of thing, to also reaching out to programs who are starting to dabble in this and are doing this but want to help troubleshoot some of the problems that we've had. You know, the basic process is actually pretty simple. Someone comes to the ER, typically requesting help with detox and treatment, or maybe identified by screening, or potentially after a non-fatal overdose, we will do a brief screening to make sure that the patient is eligible for the program and give a dose of buprenorphine while they're in the emergency department. And then the last piece is we do what we call a warm handoff and a soft landing at our Addiction Resource Center, so that we communicate with our colleagues across town, we talk about the patient, and we get back to the patient with a date and time that they're going to be seen, usually within 1 to 3 business days. We've created ways to bridge people for those 1 to 3 days through the emergency department. But really the idea is that you strike when the iron is hot and you seize on the opportunity to intervene. Because if someone with OUD is coming to the ER asking for help, you may not get that opportunity again. And if you send them away with a phone number and it's 2, 3, 4 weeks or more to be seen, generally those people are not going to do well. The other really, really cool thing I think, though, is that not only has been a huge win for patients and accessing treatment, but it's been a huge win for our providers. And, you know, ED providers, like most people, like to have problems that they can solve. And, you know, traditionally we have to admit that the emergency department and people with addiction and with opiate use problems have not enjoyed the best of relationships. But it tends to be a fantastic access point for people who are otherwise disenfranchised. When you give providers the tools to be able to intervene on a problem, it really transforms the interaction for the providers. And quite honestly, I have to say that our providers now who would have maybe tried to avoid these kind of visits will seek out these visits because they know they have something to offer and can go into the room not only with something to offer, but the ability to really engage with people on a more human level. And we've had comments from patients that really sometimes are shocked at how we're able to transform, how we're able to approach them and really help them with their problems. It gives the community of people suffering from OUD a message that here's an access point to help and to get help and to get into the healthcare system. And so what we're going to do with Project Rise is going around to other EDs and helping them start programs. Some of the nuts and bolts have to be set up locally. Like the big question for a lot of people is, who's my referral treatment center going to be? And so one of the things is we're going around to the EDs, but we're really trying to send a strong message to the treatment community that, hey, let's get you guys partnering with your local EDs to try to do this for people. And so far, it's been successful in a number of emergency departments around the state. And I'm happy to take any questions, or if you are from an ED and just want to email me or Kayla, you can do that too.
I'm slow with the technology. We'll make sure to have Noah and Ranjiv's email with our materials.
Yeah.
So in case people weren't able to grab them out of the chat box, that will show the designated contacts. And certainly Kayla is the main contact here at Qualidigm, formerly known as Quality Counts, to tell us about these programs. So I have just sort of the last slide to think about. Let me see if I get us. Just the last thing to leave you with, sort of some questions, not some data, because we don't have all the data, but I thought that this was a great article in the New Yorker at the beginning of this year to rise some of the points that are still really big questions for us and our patients. And I definitely do not profess to be the keeper of all knowledge on such things. So here's our take-home messages. We're going to look through the list. The biggest thing is to prescribe naloxone and to carry naloxone. And then finally, MICIS, as part of our services this year, we're rolling out a program where we can do one-on-one academic detailing. And what that means is myself and soon my colleague, partner in crime, Charlie Padavina, as soon as he gets going with some of this, we can come to any location in Maine, to a prescriber's office, and sit down and meet with you for an hour of individualized CME. The two topics are managing complex pain, so how to work with those really difficult patients and how to think about tapering and what types of safety valves to put in place for patients with chronic pain who are on opioids. The other topic is an overview of buprenorphine. So if you have questions like Dr. Advani was saying, what's the rationale behind this? What's the data that supports its use? What are some of the functional questions to get started? Or I've already been doing this for 6 months and I have some higher level questions. Those are the kinds of things that we can address in these one-on-one educational sessions. So now Kayla's going to take a quick look at our Q&A box, chat box.
Okay, so I'm going to read off the questions, and we have a panel. So whoever feels like they could answer best, you can jump in over each other. So the first question is, hold on. That's not a question right there.
Okay, so I see the one from Jeff Benson that talks about the MME threshold. Mm-hmm. So we have laws in the state of Maine, which is from Chapter 488, and then we have rules, which are from Chapter 21 guidelines. And here's another plug for the webinar next month on October, is it 13th? Peter Michaud from the Maine Medical Association. October 15th. Peter Michaud from the General Counsel from the Maine Medical Association is going to be going through in long version all of the rules, all of the current guidelines, all of the current legal requirements. But basically, any patients on chronic opioids do need to have urine drug screens once a year. You have to have exemptions if they're over 100 MMEs. And I think did that cover urine screens? PMP frequency, you are required to check the PMP for every initial opioid or benzodiazepine prescription, as well as every 90 days thereafter. Do they apply to MAT? I would say, is without thinking about it for more than a second, yes. When I go to my buprenorphine clinic, I'm making sure I'm checking the PMP every 90 days. My patients at my former buprenorphine clinic got a urine tox screen every time they walked in the door. And I was documenting equally as I would have for someone that I was prescribing chronic pain, but feeling pretty confident that the drug I was prescribing was far less dangerous. So let's see if we have any other questions.
Not right now, but we do have a reminder that I want to mention. So we're piloting something out with the Maine Medical Association, the Maine Board of Licensure in Medicine. That's going to allow us to immediately upload, in theory, immediately upload your information to the board for the opioid-related credits to BOLM. So the Board of Licensure Medicine will get an auto upload of your credits from like attending today. So you will not have to get the certificate. So again, this is a pilot program that we're testing out in conjunction with the MMA. They're trying to improve the process of how we track CME and getting that over to the board and making it less of a hassle for all of you. So we just want to make you aware of that. If for some reason there is an issue with it, we will still have your CME, can obviously get you that record as well.
And that includes the osteopathic board.
Yes,
It's both boards, the board of
boards.
allopathic medicine, the board of osteopathic medicine. And
They'll be asking for
you'll need your license
number and your month and day of birth.
Okay, so if you want to provide that information, then it will go seamlessly to the board. 2 quick things. The PowerPoint will be sent out along with the notes from tomorrow. And thank you to everyone. Someone pointed out that we're going back and forth referring to everyone by first names. And that is because we have all worked on these opioid projects for over 5 years together. So sometimes we forget to be very formal when we're addressing each other.
We're terrible.
But we've been in the trenches in this project for a long time. But we certainly want to make sure that we're respectful to all of our guests and make sure that we really appreciate having Dr. Nesson and Dr. Advani here. So Kayla's going to do the closing comments here.
Yeah, so just a few more closing comments to finish out the webinar. We've already gone through the questions. Just the reminder about the CME again, please just stay on until the end of the session. Once the session's over, we'll actually close the meeting, and then the next page will come up for you to complete your survey. So just wait until we close out the meeting. And then we do have those 2 more webinars coming up. So the next webinar is October 15th, and that's actually with Peter Michaud, and he is going to do the 2019 legal opioid update. So review of Chapter 488, discussing opioid laws, Chapter 21, all that fun stuff. And then on November 19th, we do have Dr. Mock back to do the prescribing benzodiazepines and opioids, the black box of increased overdose. I think it says deaths at the end, right? We have a thing in a way.
Yes.
But anyway, we've been through it before. It's a great presentation. So we hope you all will join us for that as well. I do see one more question came in quickly that
I'll respond to Dr. Braun because we want to make sure everyone can get the survey and get back to seeing patients.
Yeah, so we're going to take this down and we'll answer you, Dr. Braun, separately, okay? But thank you, everyone, for attending today. And as always, we have our contact information on this slide at Qualidigm. If you have any questions, you can contact myself or Jackie. And we hope you all have a great rest of the afternoon.